continuum, I have got two other cases which are unique in their own way to present here. So we'll straight away go into the discussion. So today's first case is a 19-year-old girl who presented to our hospital with complaints of 3 months of arthralgia, skin rash, and fever for 5 days. And patient was admitted for these complaints. And within 2 days after admission, the patient developed depressed level of consciousness, epistaxis, and seizures. And the past history was a little bit significant here. Patient was diagnosed with pulmonary tuberculosis sputum positive by in our hospital only, and she was started on anti-tubercular treatment. The patient failure to complete the treatment. She completed only intensive phase of the treatment, and she left the treatment after 2 months of taking the anti-tubercular therapy. And 6 months back, the patient was also diagnosed with the mitral regurgitation on echo. This is in another hospital with an elevated ASO titer and an elevated anti-DNase test. And she was admitted to some other hospital and was treated to the diagnosis of an acute rheumatic fever with benzyl penicillin. And the mitral regurgitation was normalized on echo, and she was discharged post that session. So this hospital, here they didn't restart her tubercular treatment. Over the course of following 3 months, again she developed progressive arthritis and chronic remitting fever and rash. The acute history being a depressed level of consciousness with the bleeding manifestation and seizure with a high-grade fever in the background. So at presentation, patient was febrile, patient was pale, she had a lymphadenopathy, which are the cervical group of lymphadenopathy and the inguinal group of lymphadenopathy. There was a maculopapular rash present during the admission. Patient had both hepatomegaly and splenomegaly. Patient had tender, swollen, reduced range of movement in the wrist, knees, ankle, and proximal and distal interphalangeal joints. And 2 days later, patient developed the reduced level of consciousness. Patient became stuporous. Patient had a bleeding from the nostrils, and patient developed one episode of the generalized tonic-clonic seizure in the hospital. Hepatomegaly persisted, and as a new sign, the bronchial breathing developed in the right upper lung fields. So this patient with a past history of the sputum positive pulmonary tuberculosis on incomplete treatment had a history of an acute rheumatic fever 6 months back. Now coming with the complaints of an active polyarthritis with a severe high grade of fever and developed some amount of encephalopathy along with the right upper lobe pneumonia or consolidation. So these are the investigation in the patient. On admission, her hemoglobin was 11.2 on day 4. That is the day she became unconscious and she threw a seizure. It was dropped to 5.1. The TLC dropped to 3,600 and platelets dropped to 45,000. So there was an acute pancytopenia developing in a patient within a span of 3 to 4 days. And ESR, which was initially 110, dropped it to 32. The MCV was pretty similar. The blood urea was a little bit high in the post admission day. And along with that, she developed an AKI with the creatinine rising to 1.4. Initial ALT, AST levels were normal, but she had some amount of transaminitis on the day 4. On the other hand, the bilirubin also rised a little bit. There was some amount of coagulopathy on day 4 with the INR of 1.4. She also developed the increase in GGT and the RA factor ANA. They came out to be negative on chest X-ray, which was initially normal on the day of admission. The repeat X-ray on day 4 showed the right upper zone consolidation. And other investigations in which we sent 2 blood culture, both grew nothing, became sterile. The MON2 was still significantly higher. The CRP was higher. The LDH came out to be 8,100. Ferritin was very, very, very high. I will tell you why we got ferritin done in this patient. We repeat the INR on day 5th. It again increased to 1.5. The triglycerides were increased. Since the patient had some amount of encephalopathy, we did a CSF analysis. Although neck rigidity was not there in this patient, as a part of the PO evaluation, we did a CSF analysis, which was pretty normal, except for some amount of pleocytosis in which patient had 12 to 15 cells, which were mononuclear cells. Although this CSF analysis was done after correction of the platelets and the coagulopathy, patient was transfused the 4 units of the platelets, the random donor platelets, and the fresh frozen plasma before doing the CSF analysis. And we did the NCCT brain as the patient had an episode of seizure, which was normal. The sputum CB-NAT was still positive for pulmonary TB, and it was sensitive for the rifampicin. The RT-PCR for COVID-19 was negative, and the COVID-19 antibodies also came out to be negative. So at this point of section, the patient had a diagnosis of an pulmonary tuberculosis with an acutely developing pancytopenia with some amount of an acute kidney injury, the transaminitis, and the right upper zone consolidation, which are manifestation of a multi-organ dysfunction developing in this patient, that too very rapidly. If you see the hemogram of the patient, the HP dropped suddenly to the 5.1. Although bleeding was not that much significant, there was only mild amount of epistaxis developing in this patient, which is not the cause for the dropping hemoglobin in this patient. So the evaluation in such particular kind of patient, the issue or the importance to be given for the acutely developing issue. So here an acutely developing issue is an altered sensorium and the pancytopenia. If you see this amount of pancytopenia developing rapidly is very, very uncommon in day-to-day practice. So we did a bone marrow as a part of evaluation of the pancytopenia. The bone marrow showed the features suggestive of hemophagocytosis with inactivated macrophages. So this patient was ultimately diagnosed with a pulmonary tuberculosis with secondary hemophagocytic lymphohistiocytosis, which is not so rare as the literature tells, because in India, this is not a first case I'm seeing with a secondary HLH in a patient of pulmonary tuberculosis. I think during my postgraduate period, the HLH was very common both in the leishmaniasis and the pulmonary tuberculosis. So India being a very highly endemic area for the pulmonary tuberculosis, so the atypical manifestations do occur in India. So we need to have a high suspicion for this particular diagnosis, because this is an emergency and has got a very high mortality if you don't consider the emergency treatment. HLH is a very deadly thing and it is a medical emergency. So HLH is an under-recognized medical emergency. So it is just a hyperinflammatory condition. Your inflammation in the body is going berserk, and this hyperinflammatory condition has got a very high mortality in your patient. And this hyperinflammation is nothing but the histiocytes in the body and the cytotoxic T cells in the body are getting activated on their own, so causing the damage to the body. So what they do the hemophagocytosis. That means these histiocytes, instead of phagocytosing the external viruses or the bacteria, they start to phagocytose. They start eating own blood cells, causing the hemophagocytosis. If you see this is a macrophage. So this macrophage has ingested the white blood cells. So if you see the white blood cells or the red blood cells inside the cytoplasm of the macrophages, that is a very typical of the hemophagocytosis. And another important thing what this hyperinflammatory condition is, since they are activated, they secrete a tremendous amount of the cytokines into the bloodstream, causing an hyperinflammatory reaction, which ultimately leading to the multi-organ dysfunction. So in the last 8 to 10 years, there have been a lot of controversies in the terminologies, whether to use a macrophage activation syndrome or to use a hemophagocytic lymphohistiocytosis syndrome as a entity. So nowadays there have been a consensus. This was given in the BMJ. The HLH is being categorized into 3 types. One is the familial HLH, in which there are inherited defects in the cytolytic pathway proteins. And this familial HLH is usually seen in infancy or in early childhood, very rarely in adulthood. And a secondary HLH, when this is triggered by either malignancy or an infection or an autoimmune condition. And if an HLH caused by the autoimmunity is being given a particular terminology, that is the macrophage activation syndrome. So macrophage activation syndrome terminology is used only when HLH occur in the context of the autoimmune disorder. In all other conditions, the term HLH is used. Only in autoimmunity, the MAS, that is macrophage activation syndrome terminology is used. So since our case was the tuberculosis induced the secondary lymphohistiocytosis, so the secondary HLH was used in our patient. So if you see the pathogenesis of this HLH, we know that these cytotoxic T cells and the NK cells, as a part of the innate immunity and the adaptive immunity, are going to affect the tumor or the infected cells. So this becomes effective in the patient due to some unknown causes. So whatever the antigen presenting cells which are presenting these antigens are not getting killed by the natural killer cells or the cytotoxic T cells, leading to the enhanced histiocytes proliferation. So there is also a mechanism involving the regulatory T cells. So these are going to regulate the activity of these NK cells and cytotoxic cells. Since this regulation is also not been there, there is a tremendous amount of proliferation of the histiocytes and all the other cells. So these try to phagocytose the body's own blood cells, causing hemophagocytosis. So in that due process, there is a cytokine storm due to imbalance between the pro-inflammatory and anti-inflammatory cytokines. So the interleukin 10 and interleukin 1 RA are the anti-inflammatory cytokines, which are going to downgrade, and due to increase in the pro-inflammatory cytokines, mainly the interleukin 1 beta and the TNF alpha, there is an excessive inflammation going in the body, causing the hyperinflammation. So I'm not going to deal the familial HLH today because it is a separate discussion, and in the part of pediatrics we will be discussing that entity. So as a secondary HLH, it can occur in an autoimmune disorder, it can occur associated in infection, it can also occur associated with a malignancy. So HLH occurring in the background of autoimmunity is called as MAS. So the first HLH was actually described in the context of the juvenile idiopathic arthritis in this patient, and also the adult onset Still's disease. These were the two most common autoimmune disorders which are very much prone to develop the macrophage activation syndrome. So in this patient also there might be an infectious trigger, although this hypothesis is not been proven yet. But this autoimmunity induced macrophage activation syndrome indeed can be seen in almost all rheumatic diseases, including the SLE, the rheumatoid arthritis. Although it is very rare, it is usually very common in JIA, that is pediatric population. So as a part of infection, worldwide most common cause is the viruses. Among the viruses, it is the herpesviridae, and among the herpesviridae, it is the Epstein-Barr viruses. So Epstein-Barr virus is notorious in causing the hyperinflammation by HLH, and it can also be seen in other viruses like HIV, the dengue, influenza, the Ebola, and very recently the COVID-19. And as far as bacteria are concerned, although it is much less common compared to the viral infection in the background, but it is seen with the tuberculosis, the brucellosis, the rickettsia, and malaria. These bacteria have been, along with some parasites like malaria, have also been implicated in causing the hemophagocytic lymphohistiocytosis. And as a malignancy, this can occur anyway during the course of malignancy. It can occur during the presentation, during the start of the chemotherapy, during the time of bone marrow transplantation. It can occur after bone marrow transplantation. It can occur after relapse. Anytime it can be seen. And it is usually associated with the hematological malignancies more than the solid organ malignancies. And all these EBV associated malignancies. So if you see this Kaposi sarcoma, and the Burkitt's lymphoma, the diffuse large B cell lymphoma. So all these are very, very common in causing the secondary HLH, and this is a medical emergency. So this HLH is a clinical syndrome with features that overlap or mimic the systemic illnesses such as sepsis and malignancy and rheumatic diseases. So people tend to usually miss the diagnosis. And also there is no agreed diagnostic criteria to date for the HLH. Like there is no single diagnostic criteria. There have been a lot of controversies. There have been a lot of other diagnostic criteria are available, but there are not particularly single diagnostic criteria available for all the HLH. The autoimmune section has got its own guidelines. The hematological section has got its own guidelines. But as a single entity, it has not been available. And it should be considered in any unwell patient who is feverish in the background in certain risk population. So this the physician should know. And whatever the diagnostic criteria, even if you have, they are mainly being given for the research purposes or the study purposes. So as far as clinical practice is concerned, you should concern any PUO patient who is prone to have or he is at risk of population having these symptoms. And one of the key population in which HLH is very much under-recognized is in a critically ill patient with multi-organ damage. Since the patient was attributed to the multi-organ damage to the sepsis, there is a tendency to give away in the management as sepsis-induced multi-organ dysfunction usually does not have any particular treatment apart from maintaining the vitals. But if the patient is having multi-organ damage secondary to HLH, patient can definitely respond to the immunosuppressive therapy. This is a very, very important thing. So any patient who is admitted in ICU with a multiple organ dysfunction, the terminal illness may be malignancy induced. Many of times the diagnosis has been missed, and post death in the post-mortem, the activated histiocytes have been recorded, and the papers have already been published regarding this post-mortem histiocytosis in a missed patient. So you need to have a very high suspicion in this patient. So how does this HLH usually present? There is no single way of presentation, but what every patient have is the fever of unknown origin. That is mean the very high degree of fever is a very cardinal feature of HLH and is seen in almost all patients of HLH, whether it is a primary, or a familial, or a secondary HLH, or a mass. So fever is always there in a patient. And if you see the patterns of fever in case of the juvenile rheumatoid arthritis or the adult onset Still's disease, there's a particular pattern called the quotidian type of fever. So this is being the typical pattern in the Still's disease. If this patient develops a continuous persisting non-remitting fever as a transition, you need to suspect the development of HLH in this patient. So persistent fever in any unwell adult or children without an attributable cause, or the worsening fever in a patient with a treated infection should prompt the investigation for the HLH. So this is a very, very important thing in the background of PUO to be practiced. And neurological dysfunction is actually can be seen. It can be from subtle changes like the psychiatric changes, just confusion may be there in the patient. Sometimes patient can develop the frank seizures and may lead to coma, as in our case. And this is a poor prognostic marker and is often a consequence of an established secondary HLH, although it can occur early in the disease course. So there is no fixed time of development of neurological dysfunction. And the most common renal manifestation in case of the HLH is the acute kidney injury, which may be present in up to 62%. More than half the patient can have the acute kidney injury. And many of them among this patient does require renal replacement therapy in the due course. And the pulmonary involvement, the most common type of pulmonary involvement is the development of an ARDS, is found in again 50% of the patients with the HLH and may manifest as an acute respiratory distress syndrome, and they may go with the need of mechanical ventilation in the due course again. So there is a variety of range of manifestations in the HLH. That's why the suspicion should be very high. So what are the key features in which you suspect the hyper inflammation in this? One of the very important feature is the hyperferritinemia, which is developing in this patient. Any patient, any febrile patient is not responding to the routine treatment, the diagnosis is not being possible, get the ferritin. If the ferritin is very high is a very key feature and it is a very critical feature of the HLH. And this is also related to the disease activity. More the ferritin level, more the disease activity it tells, and again, it carries the same amount of prognostic value with a higher degree establishing the poor prognosis. And it is the most dynamic marker. For example, if you get it on the day, it may be normal. If you get the repeat ferritin in the evening, there may be a completely, absolutely different value coming in the patient, which may have raised the ferritin to more than 10,000 within 6 to 12 hours. So it is a very dynamic marker and it can also have a prognostic value. Sometimes a dropping ferritin is a very good prognosis in your patient. And the next thing which you want to see is the hypertriglyceridemia, which is usually secondary to the liver involvement. And it may not be seen in the early disease, but it is usually seen after the liver involvement is seen, which is usually late in the disease. And hypofibrinogenemia, which is a consequence of the procoagulant activity developing in the patient. All the fibrinogen, whatever is there, is going to be consumed in the body. So this can cause the hypofibrinogenemia. So this may cause the paradoxical fall in the ESR. We know that ESR is dependent on the fibrinogen. The Rolex formation is dependent on the fibrinogen. So this dropping fibrinogen can also drop the ESR in a patient in a significant way. So if you see in our patient also, on the day of admission, the ESR was 110. We thought it is in the background of pulmonary tuberculosis, she may have a very high ESR. But on the day 4, she had an ESR of 32. We initially considered this as a error in the lab value. That too in the background of severe anemia, patient was having ESR of 32, but it is actually secondary to the hypofibrinogenemia developing in this patient. And this, along with the background of the thrombocytopenia, can cause the bleeding manifestation. And again, another cause of the bleeding manifestation in this patient is the DIC due to consumptive coagulopathy. We know a lot of the fibrinogen is getting consumed. There is a lot of thrombocytopenia occurring in the body. So there is a microvascular thrombosis occurring in this patient. And hemophagocytosis is a late feature. As I told you, this is a very important sign, which is the pathogenesis in causing the pancytopenia. But this does not correlate well with the HLH. And this is not an essential for the diagnosis of the HLH. We know that many of the conditions, we had a possibility of HLH. We do a bone marrow. Bone marrow does not suggest the hemophagocytosis. Then we have a habit of giving the diagnosis of HLH. This is not right. HLH is possible even without having any amount of hemophagocytosis in the bone marrow. It is not must to have a hemophagocytosis in this patient. Along with this, the patients have cytopenias. The patient can have the transaminitis. The patient can have other manifestations, like there may be very high LDH due to cell death. Patient may have the mild amount of the jaundice, etc. All these are very, very possible. So any adult with a pyrexia of unknown origin at risk, like patient in the background of the malignancy, patient had a diseases which can cause the HLH, check the serum ferritin. If serum ferritin is less than 500, then the mass is very unlikely. And if there is a very high ferritin, like if it is more than 10,000, then mass is very much probable in this patient. Then confirm the diagnosis along with the other investigations like fibrinogen, triglycerides. There is particular score called as H score, which is available in the internet. You can calculate and start immediate treatment. Please remember this. This guidelines tells that you need to start the treatment as for HLH as soon as the patient develops serum ferritin about 10,000 in at-risk population with PUO. You can simultaneously start the other investigations. But if the ferritin level is in the middle, like if it is between 500 and 10,000, then mass is definitely possible. Then you will evaluate for the serial monitoring of the ferritin with the fibrinogen, the triglyceride, all these things you will do, but you will wait to start the treatment till you get other evidences of HLH. But if it is more than 10,000 in the background of pyrexia of unknown origin, patient is at risk, you need to start the treatment immediately as it has got a very high mortality. So this is the 2004 criteria, which can be used in a diagnosis. So there are 9 factors which are given for the diagnosis. In this 9, if the 5 are present, then it can be considered as the HLH. First criteria is fever, which is a must. Then a splenomegaly. Then the peripheral cytopenias. The 2 out of 3 cell lines should be included at least. The hemoglobin should be less than 9, or it can be less than 10 in infancy. Platelet should be less than 1 lakh and an absolute neutrophil count of less than 1000. And the evidence of an hypertriglyceridemia or hypofibrinogenemia. Then the evidence of hemophagocytosis in bone marrow or spleen or lymph node or liver. Among these, the bone marrow aspiration is simple compared to the spleen or liver aspiration. The low or absent NK cell activity in the laboratory. The ferritin level above 500. Then the elevated soluble CD25 level and elevated CXCL9. These are the pro-inflammatory markers which are included in the criteria. So if you see this, so the NK cell activity, the elevated CD25 and the elevated CXCL9 are very difficult to get in the day-to-day practice. So that's why using this criteria, it was initially very difficult to diagnose the patient. So later on, the guidelines have been changed. There were the 4 clinical criteria and 4 immune markers given for the diagnosis of the HLH. Among this, 3 out of 4 clinical factors should be there with either one of the 4 immune markers. So there has to be either fever, splenomegaly, cytopenias, and hepatitis. 3 out of 4 should be there. Along with this, any of this marker, either there is a hemophagocytosis, or there is an increased ferritin, or the hypofibrinogenemia, or the absent or decreased NK cell activity. So if you see our patient had a fever, our patient had splenomegaly, our patient had cytopenias, and our patient also had some amount of hepatitis with the both hemophagocytosis and increased ferritin. So all these criteria or the diagnostic criteria are actually given for the research purposes to include the ideal candidates in the study purpose. But in my own experience, any patient who is coming with a very high grade of fever, who does not have any actual diagnosis, with a ferritin above 3000, with any other organ damage, should be treated as HLH if possible, and if you don't have any other alternate diagnosis. So this is what I practice. Any patient with a fever, with a ferritin of above 3000. So this is also similar for the MISC you see in the COVID, that is multi-system inflammatory syndrome. The names are different, but the pathogenesis is same here. The fever in the background of hyperinflammation causing multiple organ dysfunction. So if you see the management of this HLH, the greatest barrier is the delay in the diagnosis. I have seen many deaths due to HLH in COVID, due to maybe non-availability of IVIG sometimes a missed diagnosis. So these are very, very common. So the most important barrier is the delay in diagnosis. You need to have the high suspicion, because criteria, whatever you follow, is only for the research purposes. And goal of the therapy is to suppress the life-threatening inflammation. So the main drugs here are the immunosuppressants. This is very, very important. So this is the BMJ article, which is giving the guidelines for the management. The first line of treatment which they give is the IV methylprednisolone, that is the pulse methylprednisolone. We give at 1 gram daily for 3 to 5 days. Along with that, we give IVIG 1 gram per kg, which is 50% less dose compared to the Guillain-Barré syndrome which we use, and it is given only for 2 days here. And since the half-life of IVIG is only 14 days, there may be a need for the repeat IVIG in our patient. There are second-line treatment in a patient who has got an established mass or a secondary HLH, in which there is a clinical deterioration. Despite the initial management, you can consider the anakinra with a starting dose of 1 to 2 mg per kg, the maximum dose of 8 mg per kg. This is an interleukin-1 antagonist. As we saw in the pathogenesis, that interleukin-1 is the main pathogenic pro-inflammatory cytokine. So we use the interleukin-1 antagonist, that is anakinra. I think it is much cheaper to use anakinra, because 1 vial of anakinra costs around 5,000 rupees in day-to-day practice, whereas 1 vial of IVIG costs It is 13 to 15,000 in practice. And there are third line therapies for the refractory management. That is, the etoposide is used twice weekly for 2 weeks, then once weekly for 6 weeks. Initially in the history, this is actually the first line of treatment. The first drug which was tried for the HLH was actually etoposide. Due to the side effect profile, this has come to the third line therapy. Along with that, we need to consider the parallel treatment. And this is a better treatment chart, which probably everybody should remember. Here, the later the guidelines was changed, in which the anakinra came out to be the first line of treatment, as I told you, due to the maybe the cost issue compared to the other drugs which are available as a first line therapy. If you see the corticosteroids, the methylprednisolone can be used. If the CNS involvement is there, it is better to use the dexamethasone because of high CSF penetration by the dexamethasone compared to the methylprednisolone. And avoid this methylprednisolone if the cause of this HLH is unclear. For example, if there is a malignancy, the lymphoma may be there, which is causing the cytokine storm or the HLH in a patient. So this can actually mask this lymphoma diagnosis by giving steroid in this patient. And IVIG is also same. It is for 2 days. But anakinra, which everybody should remember, can be used as a first line of treatment due to the cost issue. And here, anakinra cannot be used unless the cytokine storm syndrome has happened in the background of CAR T cell therapy, in which the particular drug has been included, that is tocilizumab, that is interleukin-6 antagonist, which has been approved by the FDA for the CAR T cell therapy induced hyperinflammation syndrome. We know that this CAR T cell therapy is a big recent advances in the management of the oncology, in which we get a T cells from the body, then we make it insert some special antigens so that it recognizes the malignancy cells. Again, we give back the patient the same T cells which are loaded with the antigen recognition site. So these cells go and fight for the malignancies. So this has been awarded for the Nobel Prize also recently. So this CAR T cell therapy induced cytokine storm, the drug approved is the tocilizumab. This can be the entrance question here. Again, the second line drug, the etoposide, can be used. The intrathecal methotrexate can be used along with the dexamethasone in case of CNS involvement. And cyclosporine can be used as a second line therapy. And as a maintenance therapy, we can use the anakinra once weekly dosing for the maintenance, since the relapse can be very high. And you need to treat the underlying cause. If the patient had a rheumatological condition, start the biologicals or the conventional DMARDs. And if the patient has the very high activity, you can consider the rituximab or the cyclophosphamide as a part of induction therapy due to the hyperinflammation. And if the infection, the one important thing is, if the EBV driven HLH is proven, then the rituximab can be given. And if the HLH is driven by this HHV8 Castleman's disease, then again the tocilizumab is indicated, that is interleukin-6. And one very important thing you should remember is the emapalumab is a drug approved for the familial HLH. So these can be the entrance questions. So I have given you the 3 questions that can appear in the entrance. One is the drug approved for the cytokine storm in case of CAR T cell therapy is the tocilizumab. Same with in case of the Castleman's disease. If it is EBV driven, then it is rituximab. And the familial or the HLH, which is seen in as infancy, the drug approved is epamulumab. And again, along with this, you need to treat the complications, treat accordingly the neutropenia if the patient had. The patient may need in support of the blood products or the plasma therapy. Patient can be considered for the organ replacement along with the ECMO if possible. So these are very, very important in the management. So in our patient, we actually gave IVIG along with the pulse steroids. Although patient had a pulmonary tuberculosis in the background, we simultaneously started the patient on antitubercular therapy along with the IVIG and corticosteroids. Patient actually recovered by the 5th day. The patient regained consciousness on the 5th day. Presently, she is on antitubercular therapy, coming for the follow-up. I think in next 2-3 months, she is going to complete her tubercular therapy. So this is one important case which everybody should go through in the management. It's very, very important. So these are practice changing cases. So another important case which I have taken here is the 45-year-old female patient who presented to the hospital, referred from the private practitioner. So with a history of fever and chills since 2 weeks, the malaise, loss of appetite, and for this patient received the home-based treatment. She received injection zone IV OD, injection Rantac, and injection IV fluid for 5 days from the same family doctor. And this patient was referred to me in view of the new onset confusion, abnormal behavior, and not identifying the family members since 1 day. And patient is a non-case of diabetes mellitus. She is on treatment from me only. She was on sitagliptin and metformin and glimepiride. Her last HbA1c was 7.1%. So this patient on arrival to the hospital, she had the pulse rate of 96 with a temperature of 96 Fahrenheit, the blood pressure of 112/68, the respiratory rate was 22. Since she was a diabetic and she presented with symptoms which can occur in hypoglycemia, the hypoglycemia was ruled out with the blood glucose of the 108. Her general physical examination was normal. Patient had a hepatomegaly, which is 3 centimeters below right coastal margin. The spleen was stiff. Stiff was palpable. The patient was conscious, but she was confused. The patient was not oriented to the person, place, and she was irritable. The meningeal signs were absent, and there were no focal deficits. Initially, we thought a possibility of an acute encephalopathy as a part of viral. So we started the patient on the cocktail with a meningitic dose of the zone, along with the aceclopine in this patient. So we went ahead with the probable diagnosis of febrile illness with encephalitis. So this patient, she had got investigations done with the same family doctor 4 days back, which showed hemoglobin of 12.1, TLC of 9,600. The neutrophil differential count was pretty okay, although there is some amount of lymphocytosis was there seen. The platelets were 2.3 lakhs, and the doctor had also got the Vidal, which is a routine practice by all the doctors to get Vidal done. So it was showed the 1:160 as a ratio. So the family doctor considered it as an enteric fever and started the zone treatment. So if you see this patient also had a report which was done 6 months back by the same doctor for the fever, which also showed the Vidal titer of 1:160. So this is very much possible in the endemic part, like in India, where patient can have a persisting significant Vidal titers. So on day 1 of our hospital admission, she had a mild drop in hemoglobin, that is 11.2. The leukocytes were okay. But if you see, there was an eosinopenia developing in this patient, and the lymphocytosis had increased, and there was some amount of thrombocytopenia. The creatinine was okay because last creatinine was 1.2, so 1.3 did not meet a criteria of acute kidney injury. The bilirubin LFT was normal, although there is some amount of hypoalbuminemia was present. CRP was a little bit high. The Vidal was repeated in view of the possibility of enteric fever, but Vidal came out to be the same titer. If the titer would have increased, then it would have been definitely the enteric fever. The dengue came out to be negative. Chest X-ray was normal, and ESR was 41. And since we had planned the CSF, so we did a fundus. There was no papilledema. So we also got a CT head done, and we sent the 2 samples for the blood culture, and CSF analysis showed sugar of 64. In the background of blood sugar of 108, it was normal. Protein was 96, slightly increased. There is 21 cells, predominantly mononuclear, that is some amount of pleocytosis was there. Also, by looking at this particular CSF picture, we thought of a possibility of the viral encephalitis. So we also got MRI done, but MRI didn't reveal anything in this patient. MRI came out to be particularly normal. We had also sent the specimen for the rapid multiplex PCR in view of the CSF pleocytosis. The gram stain was negative, the AFP was negative, the CB net of the CSF was negative, and India ink stain was negative. Since the patient is diabetic, so this is an important practice to rule out the cryptococcal meningitis, even if patient is HIV negative. This has to be considered in India if the patient is diabetic, and if the patient has some amount of the imaging evidence of cryptococcal, because there is a one particular entity called idiopathic CD4 lymphocytopenia. In some patients, we have seen that even with HIV being negative, the CD4 count is very, very low. That is called as idiopathic CD4 lymphocytopenia. So you need to have a routine practice of sending the CSF sample for the India stain. So all the patients, whenever you do a CSF, always send the CSF analysis for the gram stain, for the culture, for the AFB, CBNAT, and the India ink. This is the routine practice which every resident should make a habit of. And we got a multiplex PCR report of this patient in 6 to 7 hours, which was negative for all viruses and bacteria. So this surprised us, but we continued that patient on cocktail, acyclovir, and all these things. But what I have seen in my practice is if the patient has an acute viral encephalitis, especially caused by the herpes virus, if you start this patient on acyclovir, the response is usually dramatic. Like if the patient has received 1 or 2 doses of the acyclovir, patient is going to respond very suddenly. Similarly, in case of malaria, if the patient is having a very high grade chills or a cerebral malaria, patient through seizure in front of you, you start the patient on artesunate. Within the first dose of artesunate, patient is going to recover completely. But this is not a case. So we still dug out the patient. The 2 samples blood culture we had sent, both came out to be Salmonella typhi. So this is a very important diagnosis here. Although in the background of Vidal, which is 1:160, which is considered as an endemic normal titer for this particular patient, both the blood culture, which is ideal test for the Salmonella, it came out to be positive in both the blood cultures. So this patient was ultimately diagnosed with a complicated enteric fever with enteric encephalopathy. So if you see the enteric fever, we know that India is a capital of the enteric fever along with the tuberculosis. So this is taking its toll even now in India. Its prevalence doesn't seem to be decreasing in spite of the availability of good antibiotics and the vaccines in the market. Although vaccination has not been routinely included in the routine immunization, but a pretty good number of patients even now are coming for the typhoid vaccine in the OPD. But even with a good amount of coverage in the vaccine, the enteric fever is not subsiding in India. So with the emergence of an antibiotic resistant strains of the pathogenic organisms, nowadays the diagnosis has become more challenging and the treatment has also become challenging. And what is important in India is the specialists barely see the 15% of these cases. It is a primary care doctor who treats the typhoid at the grassroots level. Either there is a wrong diagnosis, or if there is a right diagnosis, there is a wrong treatment, as in our case. If the initial doctor, the family doctor, thought it as an enteric fever, he didn't treat it as an enteric fever because the dose used is completely different for enteric fever of the ceftriaxone, whereas for the other treatment, other condition, it is different, as I told you in my old lectures also. So what happens, another problem is that many of these primary care doctors are forced to manage these patients in the absence of the diagnostic facilities such as blood culture and serological tests. Although this has been given in article in the JAPI, I don't believe this because blood culture is definitely readily available, but still many doctors hesitate to get blood culture. That is what we call the culture of culturing is reducing nowadays. So the blood culture should be done in every patient. This is not too much costly, hardly 300, 400 rupees it is getting costed. Even the many laboratories comes and pick in the routine places. So the blood culture before giving the first dose of antibiotic should be the routine in all emergencies, in all patients of fever in practice. So there are 2 terminologies available. One is enteric fever, another one is typhoid fever. It's better to use the terminology of enteric fever because typhoid fever is the fever which is caused by only Salmonella typhi. Whereas enteric fever can be caused by either typhi or paratyphi 1, 2, 3 or ABC, whatever you call them. So it's better to use the terminology enteric fever. So this is a guideline given by the Indian Physician Association. We have got a confirmed enteric fever case where the fever 38 degrees Celsius or more for at least 3 days. It's a lab confirmed positive culture. It can be from either blood or bone marrow or bowel fluid of Salmonella typhi. This is the only confirmed enteric case. Whereas if you confirm the diagnosis with a serological test or an antigen detection test, then it is called the probable. So these diagnosis writing habits should be made use by all the residents in your day-to-day case practice. So try to write a good diagnosis. Probable enteric fever is one which does not have a culture-proven Salmonella typhi growth. The culture-proven growth is only the confirmed enteric fever. So if you see the prevalence of the enteric fever in India per 1,000, the highest age group which is being affected is the school-going children, that is 5 to 15 years of age. At the above 16, it is around 18 to 20%. The neonates, that is the infants, are pretty much less included in the enteric fever risk group. And the carrier state is very, very important, because we know that humans are the only source. Humans are the only source of the enteric organism, that is the Salmonella typhi. So what happens when we ingest the Salmonella typhi is it penetrates the intestinal epithelial layer and gets picked up by the macrophages, and these macrophages travels to the liver. So they spread this to the liver, the spleen, and the pancreas. So this liver, the secreted bile. The bile is a very good media for the Salmonella typhi. It is very resistant in bile. That is, it is not usually, it is a very favorable media for Salmonella typhi growth, especially in the background of the presence of gallstone or any anatomical abnormalities. So this patient may become symptomatic by causing enteric fever, or they may remain asymptomatic, and they may act as a chronic carriers which maintain the infection in the community. Or another important thing is this chronically infected gallbladder with the Salmonella typhi is a very highly risk factor to develop the hepatobiliary carcinomas. The risk is around 8 to 10%. That's why in India, the hepatobiliary carcinoma, especially the gallbladder malignancies, are very, very high due to the prevalence of the Salmonella and the carrier state in these patients. So the risk factors, if you see the age, the school-going children are the particularly included in the risk group compared to the young adults, because the main route of transmission is the fecal-oral route. So especially the products like ice cream is very important in transmitting this Salmonella. So that's why the school-going children are very, very commonly exposed. And the dry weather, which is what you call the growth potentiate the Salmonella organism in the dry weather. And also in case of summer, there is a very increased habit of drinking water in the outside, or getting these cold items in the day, the roadside hub, etc. So these increases the possibility of enteric fever in the dry weather or at the onset of the rains, because there is a fecal-oral transmission. So there is a contamination of sewage due to the presence of past rains. And the particular food habits, like eating the food prepared outside the home, especially the roadside foods, and drinking the contaminated water, and also the eating the vegetables and salads which are ground with the human waste as a fertilizer. So you need to wash these vegetables and salads when you purchase it from the market. And other risk factors are like the close contacts and the poor socioeconomic status due to high population density and poor personal hygiene, lack of sanitation, the lack of safe water supply, and low latrine use, especially due to open air defecation, and living near an open air water body, and chronic PPA use is very, very important, because the gastric acidity is a very important mechanism of an innate immunity in preventing Salmonella infection. So chronic PPI use is an important risk factor for developing an enteric fever. So how this enteric fever usually presents is, in the first week, it usually presents as a fever and with some amount of GI symptoms. There may be a diffuse pain, some amount of tenderness, and constipation is very common in adults, whereas diarrhea is common in children. There may be some other symptoms like dry cough, some headache, and malaise. By the time if the patient goes into second week, this fever plateaus. So there's a particular name given for the fever in this enteric fever, that is the step ladder pattern. That fever goes on increasing from day to day. And in the second week, these symptoms progresses. And there are some typical manifestations developing in the second week of enteric fever, that is the rose spots. So these rose spots are salmon colored, they blanch on the pressure. They're mainly situated on the trunk, that is just on the abdomen, and they are usually less than 5 in number. If you search for the rose spots, it is very difficult to get. And the size is also very conspicuous, that is 1 to 4 mm, and they resolve on their own in 2 to 5 days. Why it is important is because the rose spots can be cultured for the diagnosis of enteric fever. And this rose spot culture can become positive irrespective of the prior receival of the antibiotics. And abdominal distension, the patient may develop soft splenomegaly in the second week. There is relative bradycardia getting established and dicrotic pulse, which is a very unusual pulse developing in enteric fever. So high dicrotic pulse occurs in enteric fever. This is a question for all the students. Next, third week, fever may persist if patient is not treated properly, and patient usually becomes toxic if patient progresses to third week, developing some amount of tachypnea. Patient may become weight loss, steady pulse, shock, conjunctivitis, anorexia may develop. Sometimes patient develop the abdominal complication with severe abdominal distension, piece of diarrhea, hemorrhage, or perforation. Although these abdominal complications have decreased, the typhoid state in the third week it may develop, as we see in our patient. So there are some features related to this CNS involvement in the typhoid fever. Patient can develop the meningitis, and patient can develop psychosis. Patient can develop this typhoid state, which can have some specific features. Like one of the feature is the muttering delirium and coma vigil. Coma vigil just means coma with eyes open, and there is something called a subtulus tendinous. That means an involuntary contractions or fasciculations of the tendons. So these have been regarded as the features of the typhoid encephalopathy, although these were not seen in our patient also. There is another entity called morphology. That means a tendency to pick up an unidentified objects from the bed. Like patient is looking as if he's pulling the threads from the bed. So it's a part of psychosis only. So some atypical features can develop. The patient may progress into chronic enteric fever with the illness and become cachexic, or patient might improve going into carrier state. The 3 to 5% of patients who diagnosed with enteric fever may become the important carriers. Some atypical features like patient may develop pneumonia, the glomerulonephritis. I had published one MPGN developing in a patient of enteric fever. Then the macrophage activation syndrome can occur. Severe jaundice, although very rare, can occur. The Guillain-Barré syndrome is seen. This can be seen with the typhoid and also with typhoid vaccine also. Osteomyelitis, especially in a patient of sickle cell anemia. So this is an entrance question. Then pancreatitis, although very rare, orchitis, very rare, can be seen as an atypical manifestations of this enteric fever. So this is a typical fever for a temperature chart. If you see the enteric fever, the fever from day to day goes on increasing. From first week, in second week, it becomes plateau. So this is a step ladder pattern. The fever goes a little up each day. So this is a question here. An 18-year-old girl with a fever for 4 days, which is not improving, associated with vomiting and diarrhea, and clinician suspects enteric fever on clinical grounds. And how will you prove the diagnosis? And options are the blood culture, the typhi.IgM, the Vidal test, and 1 and 2. So I will wait for the answer. So if you see the diagnosis, the early part, that is the first week, you usually rely on the laboratory features. So there may be a mild anemia. TLCs may be low to normal. The eosinopenia with the low platelets. First week diagnosis usually depends on this. If you see a thrombocytopenia with eosinopenia, eosinopenia may be seen in such an extent where eosinophils may be 0% in your differential count. So this is a very important clinical clue towards the enteric fever, especially in the background of lymphocytosis. If you see along with this lymphocytosis, This is a very, very interesting combination in taking you towards the diagnosis. LFT, the liver enzymes may be slightly rise or it can be completely normal. Clinical jaundice is uncommon and hepatic dysfunction is very rare. Sometimes there may be a confusion between the viral hepatitis and the enteric fever. If you see, some patient might come to you with a fever and vomiting, and he will get his LFT done. His bilirubin may be 3.5 to 2.6. His enzymes may be 600, with 40 being 800, and his ALP may be normal. So you think it is an enteric fever, but you have sent the blood culture, it is showing some signals in the early period. So in viral hepatitis, blood culture is usually normal. So one way to differentiate between viral hepatitis and typhoid hepatitis is the ratio between the ALT and the LDH. The type of hepatitis in enteric fever is the ischemic hepatitis. So that's why LDH gets increased very high. So the ratio becomes lesser here. So if this ratio is 9, then it is takes towards the typhoid fever. Whereas if the ratio is more than 9, then it takes diagnosis towards the viral hepatitis. Although there are no clear consensus in this is a pure clinical thing. So sometimes there may be a heavy confusion between the viral hepatitis and the initial typhoid fever, especially if you get a positive culture. So to rule out, you will get a ratio of ALT to LDH. Since the type of hepatitis in enteric fever is the ischemic hepatitis, LDH is increased predominantly compared to the ALT due to the ischemia. So any cell death in the body, LDH gets increases. So the ratio becomes lesser since the denominator is very high. So ratio of less than 9 takes the diagnosis towards the typhoid hepatitis, whereas the ratio of more than 9 takes towards the viral hepatitis. And the Widal test is a very routinely practiced and very improperly analyzed. If you see my routine practice in the last 3-4 years, I have not got any patient the Widal test done except by my duty doctor who gets it done. Widal test actually does not have any significance. The only significance is based on the demonstration of the rising titer in the paired samples 10 to 14 days apart. Yes, if you have a Widal test some weeks back, fever is not subsided. If you have done a Widal test now, this showed a significant increase in the titer, then only it becomes important. A single Widal has no value. Please remember this. Any patient, you cannot diagnose enteric with a single Widal value. So I am starting using this terminology called Widal fever rather than typhoid fever for this patient. Many a patient comes directly to you telling that you have a typhoid, treat me, or typhoid, treat me. So they actually don't have typhoid. It may be typhus fever, it may be dengue, it may be malaria, anything. So this is, although it's widely used, it is cheaper, and it is easy to perform. All the doctors, sometimes they don't have fever, they come with a diagnosis of enteric fever. So this is also very, very common. So this basically tests for the antibodies. So the antigen used to test these antibodies are the O and H antigens. So any patient, the antibody minimum time taken to develop is 5 to 7 days. So any antibody cannot become positive in less than 5 days. So this is the clue for this particular question. Although there is a tendency to choose the answer as 1 and 2 because typhoid.IgM can be used and blood culture can be used. But since it is a 4 days fever, it is better to get blood culture done in this patient rather than typhoid.M. Typhoid.M IgM usually takes minimum 5 days to become positive. So the blood culture is the one thing here the right answer is. So this Widal uses the test for O and H antibody. Among this, the O antibody develops first, next develops the H antibody. So therefore, it should never be done in the first week of fever because even if it is positive, then it is false positive that you need to remember. First, the O antibody develops, then H antibody develops. That's why there might be some discrepancies between the O and H antibody titers in your reports. So other serological tests are the typhoid test. So these actually detects IgG and IgM, which are specific to the outer membrane protein antigen. So remember all these serological tests you should remember because the question have been asked on the target antigens of this serological test. So the Vidal uses O and H antigens, whereas typhi dot uses the outer membrane protein antigen, which is specific for Salmonella typhi. So this can detect both IgG and IgM, and if you have a IgM, it signifies an acute enteric fever in the early phase of an infection. Whereas if you detect both IgG and IgM, it indicates an acute enteric fever in the middle phase of the infection or in past enteric fever with a relapse. So this is very, very important. Nowadays, we have also got the typhi.m, which is a modified version of the typhi dot, where we only test for the IgM. Here, they inactivate the total IgG in the serum sample. So it tests the antigen is specific to the specific IgM, so which enhances the diagnostic accuracy in the early period. Especially it is sometimes the sensitivity has come superior to the culture method, but and the negative predictive value and the speed is also pretty good. For example, you need to wait for the enteric fever for culture for 48 hours at least. But remember, less than 5 days, you cannot use this also. So you need to have a minimum of 5 days fever to have a typhi.m positivity. And there are other rapid diagnostic tests available like latex agglutination test. This detects an antigen. And here it could detect the antigen in the 100% of sera of the patients with a negative blood culture and a positive Vidal. And it can be used for the presumptive diagnosis. And the ideal Cubex test, it is an antibody detection test. It is a simple one-step test. The report can be available in 2 minutes. Here the antigen used is the O9 antigen, which is extremely specific for the Salmonella typhi, but not paratyphi. So a positive result is a definite indicator of the Salmonella infection, and it detects only IgM also. So the WHO recommends this serological test for the rapid diagnosis, and IgM dipstick test is also available in the routine emergencies also. So all these types of tests are available. Even the PCR has been coming now, although it is not validated for the routine practice, but nothing is better than having a positive blood culture. So the blood culture is 100% specific, but you need to have a very good amount of sample. Don't take 10 ml of blood sample here. You need to take at least 20 ml of sample. The yield increases, and the timing of the culture should be very, very important. It is not the peak of the fever as with other infections. It is during the chills. This can be the entrance question. Then it should be ideally taken before antibiotics, because if you even give a single dose of an antibiotic, the yield may be very, very low. The chance of getting positive blood culture drops as the week progresses. It is highest in week 1. And again, it requires a specialist person and lab facilities, and the patients need to wait for 48 hours. However, the bone marrow culture is the gold standard. As I told you, we had published one article in which there was a membranoproliferative glomerulonephritis caused by the Salmonella typhi, in which we proved Salmonella typhi by the bone marrow culture only. Because here yield can be positive even if the patient has received the antibiotics. So yield will not change here. So, but it is done only for the hospitalized patients. The patient need to give a consent, and it is invasive procedure. So it is better used for the long illness. The very high suspicion for the enteric fever is there, but at the blood cultures are coming negative, you can go ahead with the bone marrow culture. And stool cultures is usually helpful in detecting the carriers. You can take either a solid stool or the rectal swabs, but it becomes positive only after the first week. It's not routinely used in the day-to-day diagnosis. The other cultures which you can be done is the urine culture, although it is variably sensitive. In the background of urinary obstruction, the yield increases, but it is not done routinely. The rose spot culture can be done even if the patient has received an antibiotic. The duodenal aspirate culture may have a good sensitivity. Again, it is not a practical thing, but it is of an academic interest to improving the diagnosis, as you need an endoscopy in diagnosis or a PIN. So as far as the treatment is concerned, the very, very important thing is the drug and the dosage in the enteric fever. There is no much difficulty in remembering the dose. We have first generation drugs, We have second generation drugs, when we have third generation drugs. The first generation drugs were the three drugs, that is chloramphenicol, the amoxicillin, the ampicillin, and the cotrimoxazole. Second line drugs are the newer fluoroquinolones, and the third line drugs are the cephalosporins plus azithromycin. So nowadays, if you take this, initially the first line drugs, they usually became resistant by the year 2000. The second line drugs came into the existence. Nowadays, the second line drug resistance, that is the fluoroquinolone resistance, has also been rampant in India. The third generation drugs are usually the first line drugs as far as the empirical therapy is concerned. So either you can use a third generation cephalosporin, that is ceftriaxone, or you can use the cefotaxime, or if you want the oral drug, you can use the cefixime. But remember, dose of the ceftriaxone here is the 2 gram per day IV, and if you are using the cefixime, it is 400 mg BD. It is not 200 mg BD, and it is 400 mg UD. And azithromycin is a very good drug for enteric fever. Remember, the dose is 1 gram per day, or another practice is giving 1 gram on day 1, followed by 500 mg per day for 7 days. The cephalosporin, if you are given, should be given for 10 to 14 days. The azithromycin should be given for 5 to 7 days. Whereas if you have a susceptibility report in your hand, if the patient is completely susceptible, the best choice is the ciprofloxacin. If you compare a susceptible patient, compare the ciprofloxacin with the ceftriaxone, the clearance with the ciprofloxacin is much more compared to the ceftriaxone, because these fluoroquinolones attain a very high concentration in the gallbladder. That's why if it is susceptible, it is better to use the ciprofloxacin. If you don't have a culture report, or if it is resistant to the fluoroquinolone, it is better to use the third generation cephalosporin. You can use either ciprofloxacin or ofloxacin. Remember, norfloxacin is useless for enteric fever. You cannot use the norfloxacin. And as far as the respiratory fluoroquinolones, that is neofloxacin, sparfloxacin, gatifloxacin, and gemfloxacin, they are also susceptible, are not routinely used for the enteric fever purposes. The alternate treatment are the first line drugs, that is the amoxicillin, the chloramphenicol, and the trimethoprim sulfamethoxazole, that is the cotrimoxazole, can be used if it is susceptible. So if you look at this resistant pattern in the typhoid fever, initially we had a non-resistant typhoid pattern, that is, it was sensitive to first generation, the second generation, and third generation. Then came the multi-drug resistant typhoid fever. So what is multi-drug resistant typhoid fever? Definition is, if it is resistant to the first generation drugs and the sensitive to the third generation drugs, that is cephalosporin and azithromycin. It is resistant to the chloramphenicol, it is resistant to the amoxicillin, ampicillin, and it is resistant to the cotrimoxazole, and it is resistant to the fluoroquinolone also. Then it is being labeled as the multi-drug resistant typhoid fever, which is in circulation in India right now. If they can ask sometimes a specific strain of the Salmonella typhi, it is also called as H58 strain. Then there came an extensively drug-resistant typhoid fever, as I told in the last class, in the Pakistan. There was an outbreak in 2018. Here, it was resistant to the first generation drugs, that is chloramphenicol, ampicillin, amoxicillin, and cotrimoxazole. Also resistant to fluoroquinolones. Along with this, these drugs also had a resistant to the cephalosporins, that is third generation cephalosporins. Here, the drugs were resistant to the carbapenems, plus azithromycin was resistant. Nowadays, there is an unique Salmonella typhi which is circulating here, that is ESBL positive typhoid fever. Here, it is an extended spectrum beta lactamase positive, that is producing typhoid bacteria. So here it can be resistant to the ceftriaxone, but it is usually sensitive to the first line drugs like chloramphenicol or the ampicillin, amoxicillin, and cotrimoxazole. It can be sensitive, where it can be resistant to the ceftriaxone. That is what is called as ESBL positive typhoid fever. So sometimes whenever it is called as history repeats. the drug which you are trying is not working, you can go ahead with the older drugs of chlorphenicol or amoxicillin in giving the treatment. And the prevention, we know that the hygiene should be maintained well. Along with that, as active prevention, we have got the vaccines available. Two types of vaccines are available in the world. One is the polysaccharide vaccine using the VI antigen. Another one is the oral antigen. So in the oral, it is a live attenuated vaccine, which is available as an Enteric coated tablets, whereas liquid is available as an injection. The amount of bacteria is a 25 microgram. Here it is 2 × 10⁹ bacteria. The vaccine is used as a single dose, whereas tablets are given as 3 tablets. 3 Enteric coated tablets are given on alternate day 1, day 3, day 5. So the injection is pretty well tolerated, whereas the tablets have got minor side effects like nausea, vomiting. Sometimes the GBS has also occurred owing to the seriousness. And since it is the inactivated vaccine, the injectable vaccine can be given in HIV. And since the oral vaccine is a live attenuated vaccine, it cannot be given in a patient who is immunocompromised, HIV, and pregnancy. The polysaccharide vaccine has been approved for children more than 2 years, whereas oral vaccine is approved for children more than 6 years. The booster dose is a controversy, although WHO does not give any clear-cut evidence. But in a risk population, every 2 to 3 yearly, you need to get the vaccination done in the susceptible patient. There are other vaccines also available in the market. They have got a combined vaccines for the hepatitis A and typhoid that is called as Viatim, and there is also Hepatrix with the same combination. So this is in brief about the enteric fever and the infectious disease case reports. So you need to think before you treat in every patient, and similarly in exam. You need to think before putting the right answer, and to think you need to read. This is a very, very important thing. So in the next class, we will take the second part of the CNS infections. And in the next 2 to 3 class, we'll try to finish out the infectious disease, and we'll go to the next part. Thank you. If you have any doubt, you can ask.
Rajashekhar, sir?
Yeah.
Do we conclude the session, sir?
Yeah.
It was indeed a comprehensive clinical class. The discussion was very useful to us, sir. Thank you so much for a well-prepared presentation, and we're ever grateful for your time, for the time that you take out to teach and guide us. And we look forward to all your future sessions with us. And I'd also like to thank all the active participants in this session. Thank you, one and all.
Thank you.